right, so picking up from where we left off after the cardiology review, here's part 2. Here we are. If the EKG or ECG leads are applied correctly, the PQRST configuration should be inverted in which lead? So, right, we remember that the P wave is usually upright, and then your QRST is also kind of in the same fashion. The only lead that is inverted is in our long forgotten AVR, where the P wave, remember the view is different, and the QRS goes this way. Actually, the T wave goes down. A physiological effect of sympathetic nervous stimulation includes what? So if the sympathetic nervous system is being stimulated, right, this is your fight or flight response, which means that you are going to have dilation, right? So it's good. You're going to have a faster heart rate. You are going to have constricted blood vessels so that everything is shunted. So, right, so this dilation isn't correct. The heart rate is going to go up. So that means that your conduction velocity is not going to be slower. It's going to be faster. And again, not a negative dromotropic effect. Your heart rate's going to be picking up. So the best answer here is C, dilation of the bronchioles. The amount of blood that is pumped out by either ventricle per minute is called, right? We talked about this. This is your stroke volume times, your heart rate equals your cardiac output. Your answer here is B. The regular cardiac rhythm with a rate of 104, upright P waves, a PR interval of 0.14 seconds, and a regular QRS should be interpreted as what, right? So automatically it's a tachycardia because it's over 100. P waves are upright, that's good. PR interval is 0.14, which is fantastic, and a regular QRS, so right, this is looking kind of sinusy. So that means it's not a normal sinus, that's between 60 and 100. Supraventricular is over 150. And a junctional tachycardia doesn't have P waves. So A, sinus tachycardia. A presence of a J wave on the EKG is an indicator of what? Excuse me. So, right, in the EKG you have your P, you have your QRS, you have your T wave. Your J wave is a little tiny one after that is indicative of hypothermia. A 67-year-old man presents with severe hypertension, dyspnea, coarse crackles in all lung fields. He has a history of an MI. What intervention will have the most immediate and positive effect? Okay, so supplemental oxygen, I mean, maybe. We'll hold on to it. Sublingual nitroglycerin up to 3 doses. I mean, it's in your protocol for APE, which we're assuming that this man is an APE because of the severe hypertension, dyspnea, and coarse crackles, right? That's your hallmark characteristics. IV access and furosemide, no, because furosemide is not immediate. There's nothing immediate about Lasix. Lasix takes a while. Positive end expiratory pressure ventilation. This is your answer right here, right? Because immediate and positive. That's where you're going to see your most change in positive there. In contrast to stable angina, unstable angina occurs following periods of strenuous exertion. Now that's stable angina, does that. Awakens a patient from his or her sleep. Yeah, that's up there. Indicates that myocardial necrosis has occurred. No, it's just injury, right? We could still potentially fix it. Is less frequent, but is associated with more pain. No, not necessarily, right? Unstable angina is not associated with strenuous exertion. It is, and it just lasts longer, right? It no longer follows that predictable pattern that stable angina follows. So your best answer here is awakening the patient from sleep. The key to interpreting the Mobitz type 2 second degree block is to remember, right? So let's just remember that the Mobitz type 2 is, right? And then the next one looks like there's no winky back, right? It's not going, gone. It's a consistent PR interval with all of a sudden a dropped QRS that's missing, right? Oh goodness. Undo. I don't know why we're zooming. Let's see if I can unzoom that. There we go. Your PR interval is constant. Yeah, so PR interval is constant. That's good. Type 2 is always regular. No. Right? Because it's still the type 1 and the type 2 are technically irregular heart rhythms because you have those drop beats. The most type 2 second degree AV blocks have more than 2 non-conductive P waves that occur in succession. No, it's usually just one, picks it right back up because it's regularly irregular. In this type of heart block, the PR interval gets progressively longer until a P wave is not conducted. No, that's your type 1. That's your winky back. So your best answer here. PR intervals of all the conductive P waves and their corresponding QRSs are constant. Torsade de poids, a variant of polymorphic ventricular tachycardia, often caused by a prolonged QT. So polymorphic, yeah, that's one of your buzzwords right there. Generally less serious than monomorphic. No, we treat that, and then we also do treat it in the field. A lethal ventricular rhythm, yes, caused by ingestion or injection of a CNS depressant drug. No, it could be caused by a number of different things. Usually it's a magnesium issue. Stop it. Presents with, we're zooming again. I don't know why we're zooming. Presents with wide QRS complexes that are, oh no, that's wild. Let me make it small again. Presents with the wide QRS complexes that are all of the same shape, size, vector direction. No, because they're not the same size, shape. They're polymorphic. So your best answer is A. I'm not going to turn the pen back on in fear of that doing something strangely bizarre again. Stimulation of the parasympathetic nervous system completely blocks the AV node, preventing ventricular depolarization. No. Slows an SA nodal discharge and decreases conduction. Yes, that's a thing. It's characterized by a large P wave and PR interval shorter than normal. No, that isn't indicative of a parasympathetic nervous system stimulation. Causes a decrease in the production of epi and norepinephrine. No, it's here. Slows your SA nodal discharge, right? This is why people pass out on the toilet, because there's a stimulation of the parasympathetic nervous system. It slows the heart rate down. This is a funky pen. And it drops their BP. And then you're working up a cardiac arrest in the bathroom. The blank represents the end of ventricular depolarization and the beginning of repolarization. So your J point is in between, right? That's usually the point that we look for, right? Between the, let's do our drawing, right? right here, or J point, right, where the end of where the ventricle is, and the beginning, or the depolarization, and the beginning of repolarization, which is your T wave. So repolarization is not here. Your TP interval is all the way over here before the next beat. That's not it. And your ST segment is not really telling you anything about depolarization or repolarization. That's that pause, the isoelectric pause in between. Best answer is J point. First degree heart block that has a PR interval has a PR interval greater than 0.2 seconds because there it is. There's your answer. Each impulse that reaches the AV node is delayed slightly longer than normal. Right? Impulses generated by the SA node traverse at accelerated rate. No, it's because it's slower. Depolarization in the atria occurs slower than one would expect. No, because it's the pause at the AV node. Primary pacemaker is not the SA node with an ectopic trigger. Now, A. Shortly after administering 4 milligrams of morphine to a 49-year-old woman to manage her pain, you notice a decreased level of consciousness. She is now hypotensive, bradycardic, and hypoventilating. That's a bad day. What should you do? Immediately intubate her? No. Assist her ventilations and administer naloxone. Sounds like a good plan. Administer 0.5 milligrams of atropine and reassess her. No, it's not going to fix her problem. Elevate her legs and give her 500 milliliters saline. Also not going to fix her problem. It's due to the morphine. VFib occurs when cardiac cells in the ventricles fail to completely repolarizing, resulting in a decrease in ventricular automaticity, which might actually be the opposite of what VFib is, right? Because VFib is like all the little ventricular cells getting a little too excited about life. Many different cells in the heart depolarize independently rather than an impulse to the impulse from the SA node. Maybe. Sounds good so far. Ventricles become the primary pacemaker for the heart, resulting in a rapid and irregular ventricular rhythm. No, because if the ventricles become the primary pacemaker, it won't be rapid. It'll be between 20 and 40 beats a minute. Not fibbing. Ventricles quiver rather than contract normally, while organized atrial contractions continue as normal. No, because there are no organized atrial contractions. Close. They were started off the sentence really good, but there's no atrial contractions. So your best answer is here, is B. I'm getting the hang of this now a little bit. All right. If the defibrillator you are using is biphasic, and you're unsure of the appropriate starting energy setting, this is just a clear memorization, right? You're defibrillating with a biphasic. It starts at 200. Period. End of story. Classic sign of A flutter is, right? Remember A flutter. We have those really cute sawtooth guys, right? Irregular but consistent R to R interval. No. Presence of sawtooth or picket fence F waves. Well, hey friends, there you are. Constant 2-to-1 conduction ratio, not all the time. A ventricular rate less than 100 beats a minute. Again, not all the time. Best answer. Sawtooth, picket fence, F waves. You are performing CPR on an intubated elderly woman. A proper ET tube placement has been confirmed. You should do what? Administer 2.5 milligrams of EpiV, the ET tube, and hyperventilate to ensure joint. No, don't do that. Direct your partner to deliver one breath every 3 to 5 seconds. Close, not 3 to 5 seconds. That's very fast. Instruct the EMT to pause after 30 compressions so your partner can deliver 2 ventilations. I mean, if she hadn't been tubed, sure. But remember that you have a tube in place, or a tub/L. She's tubed. Perform asynchronous CPR while ventilating the patient at a rate of 8 to 10 breaths a minute. That's your best. You just need to remember that you are moving to a more continuous natural breathing experience while pumping on the patient's chest. Patients experiencing a right ventricular infarction may present with hypotension. Yes. Should not be given baby aspirin. No, they should get baby aspirin unless they're allergic to it. Usually have anterior myocardial damage. No, because the right ventricle is the opposite side of the anterior side of, not even the opposite side, it's like your anterior wall is here, right? This is your anterior wall right here. The right side's hanging out over here, and then you have your posterior on the other side in the back, being all posterior and stuff, while your anterior is the opposite of that. The ventricle's just like off to the side looking at like, hey guys, what you doing over there? Woo. So no. Often require higher doses of morphine. No, it may present with hypotension, right? Remember when we were doing our 12-lead placement, in order to make sure they have V1, V2, the little pen isn't working great, V2, forget this, V3, V4, oh, no, we're zooming in by accident. Undo. That we would move V4 over to see if there was right ventricular wall involvement. And if there was involvement, we would be very cautious when administering nitro because you could tank the patient's blood pressure. That's the bigger problem. So your answer here is A, presenting with hypotension. After defibrillating an unresponsive pulseless and apneic patient who presents with VTAC on the monitor, you should, again, okay, you've gotten your baseline rhythm, reassess to see if it's changed. You just assessed, so no. Take no more than 10 seconds to assess for a pulse. You've already assessed for a pulse. How many times are you going to check for a pulse? Once is enough. The dead doesn't get much less dead unless you fix it. Deliver another shock if the cardiac rhythm is unchanged. I mean, you should be shocking it, but you should be resuming CPR after you've shocked, right? You defibrillated, right? You do shock, and then you shock, and then you do CPR. This is really awful, sorry. CPR, and then you see if it got better or worse, and then you can shock again. There are rules that we follow. Which of the ECG waveforms represents ventricular depolarization? We talked about that above, right? So you have your P wave, your QRS, and then your T, which is just feeling really fluffy today, right? So we have atrial depolarization. We have your QRS, which is ventricular depolarization, and then your T wave, which is ventricular repolarization. So it's not your T wave. Your ST segment's isoelectric over here. It means nothing. The U wave is not here. Usually that's over here, doing something else entirely. It's your QRS complex. All right. A second degree heart block, Mobitz type 1, remember we talked about type 2 a little bit a while ago, occurs when the PR interval progressively grows narrower until there's a P wave that's not followed by a PR. No, it's getting wider, not narrower, so wrong. Each successive impulse is progressively delayed until one impulse is blocked from entering the ventricles. I mean, that sounds pretty good so far. It's a little wordy way of saying it, but sounds okay. More than one successive impulse from the SA node is blocked at the AV and not allowed. No, it's usually just one, right? Every other impulse is blocked. The AV node does not depolarize. Now, B. The downslope of the T wave, so let's just draw a little guy again. QRS T wave. So we're talking about from here down. This part is the strongest part of ventricular depolarization. No, because this is repolarization. You're having a tiny problem here. So no. represents a state of absolute ventricular refractoriness, that's not a word, in which another impulse cannot cause depolarization. If you remember, this is your absolute side, and this is your relative side. All right, enough. I get relative side. Let's go with it. So no, this is your this is, oh Lord, again. Represents a vulnerable period during which a strong impulse could cause depolarization, resulting in lethal arrhythmia. Yes. Is the point of ventricular repolarization to which a defibrillator is synchronized to deliver electrical energy? No. That's your R wave. That's where we sync up to C. After all that. It's C. It's still C. Jesus. Okay. You have just administered 0.4 milligrams of sublingual nitroglycerin to a 6-year-old woman complaining of severe chest pain. You have also started supplemental oxygen and an IV in place. After 5 minutes, the patient states the pain is not subsided. What should you do? Yes, you should repeat the nitro, but you need to check her blood pressure first, right? Reassess before you do anything else. A drug that possesses a positive chronotropic effect, right? So it's going to increase one of the aspects of the heart, chrono being the heart rate. So you're going to have an increased heart rate. Cardiac arrhythmias following an acute myocardial infarction are uncommon within the first 24 hours. Lies. Dirty, dirty lies. Typically manifest as AFib or ATAC. Again, no. Usually it's a ventricular in origin because that's usually the larger part of the heart that's affected. Tend to originate from the ischemic areas around the infarction. Yes, I like that one. Originate from the center of the infarcted tissues. So remember when we talked about the area of infarct, the center is the most damaged with like less damaged donut rings all around, where these ischemic ones on the outside are the most irritable, which means when they're reperfused, then they get the most angry. So the answer is C, tend to originate from ischemic areas around the infarction. A hypertensive emergency is most accurately defined as what? Blood pressure greater than 170/90 with a severe nosebleed. No, it's impressive, but it's like not a hypertensive emergency. An increase in blood pressure due to medication non-compliance. Not necessarily, because it might not be due to non-compliance. The patient might be taking their blood pressure medication, but it's not strong enough. An acute elevation in blood pressure with signs of end organ damage. I like this one so far. Elevated blood pressure accompanied by a frontal headache. There is plenty of patients with a hypertensive emergency who never end up with a headache. Best answer. End organ damage. Conscious 41-year-old man complaining of chest heaviness, mild shortness of breath, and high blood pressure began 2 hours ago. He takes clonidine for high blood pressure. His blood pressure is 160/90, heart rate 140 irregular, respirations 22. He's somewhat labored. Cardiac monitor displays a narrow complex tachycardia and lead 2, which is not indicated for this patient. Right? Should you give him adenosine? Maybe. Maybe not. 140, right? Is that high enough? No. Usually your cutoff is 150. 12 lead? Yes, definitely do a 12 lead. IV access? Yeah, I also think that's a necessity. And he's experiencing chest heaviness. Would you not give him aspirin? Yes, adenosine. Adenosine is least appropriate in this case. Monomorphic ventricular tachycardia presents with wide QRS complexes of common shape. Yeah, so far, so good. Characterized by QRS complexes that vary in size. No, because we're looking at monomorphic. If it varied in size, it'd be torsade d'appoint. Is treated as VFib if a pulse is present. No, because if you have VTAC with a pulse, you are much nicer than VFib, which never has a pulse. Is often irregular with occasional non-conductive P waves. No. Presents with a wide QRS complex, common shape. A demand pacemaker. Attaches to atrias and ventricles, only generates an impulse if it senses that the patient is in VFib. No, that would be a defib. We're going really good here at this pen today. Generates pacing impulses only when it senses the heart's natural pacemaker has fallen below a preset rate. Yes, so far that sounds good. Sends out single electrical impulses when the patient's inherent pacemaker size exceeds 150. Again, you're fibbing here. That would be a defib, not a pacemaker. It's easily identified on a cardiac rhythm strip by noting the presence of pacer spikes before all of the QRS complexes. See, that's the difference. Before all, right? A demand pacer only works when it's needed. B. A regular old pacemaker, just as a pacemaker, this would be a correct answer. But it is not. It is a demand pacemaker. Moving on. The recommended first-line treatment for third-degree heart block associated with hemodynamic compromise is an epi infusion. No. Atropine. I mean, it's in your protocol, but it's not going to do it if you do anything for a patient in hemodynamic compromise. Transcutaneous pacing, I like that. That's immediate, right? This is your medicine or Edison vibe. Or a dopamine infusion. Not a dopamine infusion. Transcutaneous pacing. Treatment for sinus tachycardia should focus on correcting the underlying cause, relieving pain and anxiety. I mean, is that the cause? Decreasing heart rate. Do you always want to do that? What happens if that's the only thing keeping that patient alive right now, right? Do you really want to take that away from them? No, we don't want to do that. That's a bad idea. Or administer IV fluid boluses. I mean, there comes a time when your patient might not need an IV fluid bolus. So the best answer is correcting the underlying cause. Well, we have a little Zoom fest. I don't know what's going on here. Which of the following occurs at the AV node during a third-degree heart block? Every third impulse is allowed to enter the ventricles. No, it has nothing to do with that. All impulses are blocked from entering the ventricles. I like this one so far. Impulses bypass the AV node and enter the ventricles. No, that's the Wolff-Parkinson-White. There is an abnormal delay in conducting impulses. Yes, there is a lack of delay. All impulses are blocked. A wide QRS complex preceded by a normal P wave. All right, so let's see what this is going to look like. A little P wave, right? And then we have a wide QRS and a T wave. Rapid conduction through the ventricles. No. The faster it goes, the narrower the QRS. An abnormality in ventricular conduction. Not like that one. That the rhythm is ventricular. No, because you have a P wave. A delay in conduction at the AV junction. No, because that would be the PR interval, not the QRS. An abnormality in ventricular conduction. In contrast to a patient with asthma, a patient with left-sided heart failure will present with a dry, non-productive cough and diffuse wheezing. No, patients with left-sided heart failure also have a fluid problem. There's such a delay. Work with me. There we go. Hyperinflated chest, accessory muscles, and expiratory wheezing. That's COPD. Where you would get the gist. Typically, younger patient with a history of upper respiratory infection. No. Experiences, usually an older patient, experiences acute weight gain and takes medications such as DIG and a diuretic. That sounds right. An early upright complex that breaks the underlying rhythm with a P wave that differs in shape and size from other P waves is most accurately described as, all right, so we have a P wave, so it means it's coming from the atrias, right? So it's not a junctional escape complex. There's no real, like an atrial escape complex is not really a thing. Wandering atrial pacemaker is 3 different P waves right? And it doesn't break up the underlying rhythm. It is an underlying rhythm. So your answer here is a premature atrial complex. Depolarization, where'd it go? A brief pause between the P wave and the QRS complex represents depolarization of the inferior part of the atria. No. A momentary conduction delay at the AV junction. Yes. Period of time when the atria are repolarizing. No, that gets buried inside the QRS complex. Full dispersal of electricity throughout both atria. No, that's your P wave. Momentary conduction delay. Q waves are considered abnormal or pathologic when greater than 0.02 seconds wide and consistently precede the R wave. No, it's okay. That's not terrible. Are not visible in these 1 or 2. I mean, if you have to go searching for them, then they're not abnormal. Present in the patient experiencing chest pain or discomfort. I mean, not a good thing, but not necessarily a bad thing. You haven't told me anything about what they look like. More than 1/3 the overall height of the QRS complex in lead 2. That's your answer. As we zoom over here, I don't know why we're zooming. On the EKG graph paper, amplitude is measured in blank and width is measured in blank. So amplitude, right, is up and down. Amplitude's up and down. And we measure that in millimeters, right, because we're talking about like ST elevation, that's millimeters. And width, left to right, is in seconds, right, because that's like we're traveling in time. We talked about time is horizontal. So your answer is millimeters, milliseconds. When managing the cardiac arrest, appropriate dosing regimen for epinephrine is. And this is just remembering that this is your dosage for your protocol is 1 milligram of a 1 to 10,000 solution every 3 to 5 minutes. After delivering a shock to a patient in pulseless VTAC, you should, this is BLS, resume CPR. You don't check for a pulse, you don't reassess, you just start CPR and go from there. Another brief memorization question that you should have had down. PR interval should be no shorter than blank seconds and no longer than blank seconds in duration. Your answer is C, 0.12, 0.20. You are on scene treating a 3-month-old infant who has no pulse and no spontaneous respirations. CPR has been initiated. You are attempting to gain IV access, which would be an appropriate site if IV access is delayed. 3 months old, without a doubt, IO. Okay, you're not gonna go futzing around anywhere else. IO is your best option. The effect on the velocity of electrical conduction is known as, and we talked about this, right? Know the difference between your inotropy, chronotropy, and your answer, which is dromotropy, right? Dromotropy is your velocity of conduction. I don't want you. A delta wave is identified on a cardiac rhythm strip as. So remember we talked about delta waves in relation to WPW, right? That's when it sort of bypasses the, hold on, let me get that pen. The P wave, it bypasses the pause at the AV node, right? So you get this kind of upward slope in the delta wave. So that rapid R wave is called the delta wave. Okay, because it's not being stopped at, answer's A. The impulse is not being stopped as it normally should at the AV junction or the PR interval. So you get that kind of, what are we doing? Again? You get that upward swoosh into that's called the delta wave. We're just having a little fit here. Just trying my patience. Come on. Common causes of bradycardia, right? Hyperthermia will increase heart rate. Beta blocker use, yeah. Height exercise, maybe, maybe not. Amphetamines, definitely not. If you're actively exercising, you're going to be tachycardic. I don't think you should be reading too deeply into this question that, oh, you've exercised, your resting heart rate's going to be bradycardic. Your best answer here is beta blocker use. Which of the following statements regarding oxygen administration for a patient experiencing an acute MI is correct? We talked about this in depth, right? Evidence has shown that high concentrations of oxygen reduce mortality. Lies. In order to prevent hypoxic injury, do not give any patient with an MI more than 2 liters. No, if the patient's having significant shortness of breath, you're going to give them more oxygen than that, right? Their pulse ox is low, you're going to give them more oxygen than that. Any patient experiencing an MI should receive high flow oxygen. Again, no. If they're not having a hard time breathing and they have a good pulse ox, you're not going to give them high flow oxygen. D, treatment with oxygen should be individualized and titrated. Best answer, best medicine. You have accidentally disconnected a central IV line on a critical patient while you're en route to the hospital. As you arrive, patient becomes cyanotic, weak, dyspneic. Rapid pulse, begins to lose consciousness. What have you done? Well, he's not going to be fluid overloaded because you accidentally disconnected it. He's probably not hypovolemic because he's probably not bleeding out everywhere. The line hasn't moved. You've moved the line. It's not infiltrated. The best answer is an air embolism. When monitoring a patient's cardiac rhythm, it is most important to remember. Heart rate below 60 must be treated immediately? No. Many patients with acute MI experience asystole. Again, no. The EKG does not provide data regarding the patient's cardiac output. That sounds like a good answer. The presence of a QRS complex correlates with the patient's pulse. Again, no, because if you have a patient who is in cardiac arrest and VTAC, they have QRSs, so it doesn't mean that they have a pulse. So your best answer here is C, which of course is not highlighting. That would be too easy. C. Right atrium, right ventricle, part of left ventricle are supplied by, and this again is just studying and memorization, right coronary artery. Okay, I mean really, common sense, right atrium, right ventricle, it's going to be the right coronary artery. When applying the precordial leads, lead V1 should be placed. Now, we talked about this, right? All of your precordial leads are on the left side, except for lead V1, which is on the right sternal border, your option D. Spironolactone is what? Again, this is a little bit of kind of having some common knowledge, common medical knowledge, and being familiar with medications. Spironolactone is a diuretic. Which of the following drugs would be most effective when treating a patient with hypotension secondary to vasodilation? And this is a little bit of knowing how your medications work, right? Dopamine is dose dependent. Propranolol is not going to help hypotension, right? It's just going to slow the heart rate down. Isoproterenol, even if you're like, I don't really remember what this is, it's okay, because what causes vasoconstriction? Norepinephrine. Layers of the heart beginning from the outermost layer, yet again, studying outermost epicardium, myocardium, the muscle, endocardium, the inside lining. Bombardment of the AV node, allowing another impulse to stimulate cardiac cells that have already been depolarized, is called what? Well, apparently it's gotten deleted, but the answer, and I'll put it in here, is D, reentry. Or My computer's tired. A 70-year-old man calls 911 because of generalized weakness and difficulty breathing. When you arrive, you find him seated in the recliner, conscious and breathing without difficulty. Your exam reveals tenderness to the right upper quadrant, edema to his ankles, and distended jugular veins. He tells you he takes Vasotec for hypertension and Maxide for his swollen ankles. His vital signs are stable. Most appropriate treatment, right? Are you going to give an IV of D5W? No. High flow oxygen, vascular access, 1 milligram per kilogram of Lasix and transport. I mean, That's a little aggressive for a patient when a physical exam is he's A-OK. Oxygen cardiac monitoring IV. I like that one. 12-lead vascular access and morphine. Why are we giving him morphine? Seems nice, chill, not in pain. So your best answer there is choice C. Presence of dizziness in a patient with a suspected MI is most likely the result of. We talked about this too, right? Dizziness is commonly a cause of reduction in cardiac output. You're called to a 48-year-old man semi-conscious. Patient's wife escorts you to the patient, tells you the patient had an episode of chest pain the day before but refused to go to the hospital. He's responsive to pain only and is markedly diaphoretic. Blood pressure is 70/50, pulse is 140 and thready, respiration is 28 and shallow. Cardiac monitor reveals sinus tachycardia in lead 2. 12-lead reveals evidence of MI. You should. All right, so 1. Start an IV line, administer 5 milligrams of midazolam, intubate him, ventilate him, transport, and then start dopamine. No, just start to finish, no. Place patient in a semi-Fowler position to facilitate breathing. Administer oxygen. Non-rebreather. Begin transport, IV en route, and give him fluid boluses. No, I don't like that one either. Because if he's breathing shallowly, you should be breathing for him. Keep the patient in a supine position. Insert a nasal airway. Assist ventilations with a BVM. Transport. Consider access while en route. Consider fluid bolus and start an infusion of dopamine. Yes. Yes, baby medic. That is what we do. Elevate his legs, ventilate, and begin transport. Give him 6 milligrams of adenosine to slow his heart rate. Don't do that. That's going to kill him. C. Your answer here is C. That is what we do, baby medics. Assessing an anxious patient who presents with tachycardia. You must. Don't prepare for cardioversion. Please don't. You don't need to midazzle your patient. Obtain a 12-lead before initiating. I mean, potentially. Determine if the tachycardia is causing hemodynamic instability. Yes, right? Because you want a full picture of the patient before you start doing stuff. Common complaints in patients experiencing an acute coronary syndrome include all of the following except chest pain. That's good. Palpitations. Yeah, that's good. Headache. No, probably not. Or fatigue, which we talked about, right? Women deal with fatigue. Your best answer is C, headache. In contrast to the right side of the heart, the left side of the heart is a relatively low pressure pump that must stretch its walls in order to force blood through the aorta. No, because the right side of the heart doesn't pump through the aorta. Drives blood out of the heart against a relatively low resistance of the pulmonary circulation. Yes, so far I like that one. Drives blood out of the heart against a relatively high resistance to the systemic circulation. No, that is the left side of the heart. So yes, that is the left side of the heart. High pressure pump sends blood through the permanent circulation lungs. No. Drives blood. Read your question carefully. See how that just whoopsied there? Atrial kick is defined as an attempt of the atria to contract against closed valves. No. Increased preload pressure as a result of atrial contraction. Yes. Blood that flows passively to the ventricles. No. That's what you get without atrial kick. Pressure of on the AV valves during ventricular contraction. No. Best answer is B. Excuse me. Paroxysmal nocturnal dyspnea is defined as acute shortness of breath that suddenly awakens a person from sleep. Yes. Inability to function at night due to severe difficulty breathing. Not quite. Dyspnea brought on by excessive movement during sleep. No. Sitting upright in a chair to facilitate effective breathing. I mean, that's usually an end result of what's going on, but the actual answer is A, acute shortness of breath that suddenly awakens a person from sleep. The SA node will. Well, it doesn't function as a heart secondary pacemaker here in the bottom. The intrinsic firing is not 40 to 60. Generally, it can't. It can go faster than 100 beats a minute, right? Because you still have sinus tachycardia. And will outpace any slower conduction tissue. Your best answer there is A. Oh, that again. Immediate treatment for a patient with an acute MI involves administering up to 3 doses of nitroglycerin. No, to administer every 5. Elevating the patient's legs 6 to 12 inches. That doesn't help in an MI. Reducing myocardial oxygen demand. Yes, we'd want them to not increase the damage that's being caused to their heart by a lack of oxygen. Give them oxygen via non-rebreather. We just had a long discussion about that too, right? Not always appropriate. Reduce myocardial oxygen demand. Regardless of a patient's presenting cardiac rhythm, the first IV or IO drug that should be given is... There's more to this question. Oh no, it's cardiac arrest. A vasopressor, calcium chloride, an antidysrhythmic, or an inotrope. Now, no matter what, the first medication that you're giving is epi, which happens to be a vasopressor. Antidysrhythmics are on there also if you're doing VFib or VTAC, but they come third in line, right? They come after your second or third dose of epi because you want to make sure you get that vasopressor aboard. Supraventricular tachycardia is most accurately defined as an irregular tachycardic rhythm below the AV. No, it's above the AV junction and it's to be very regular. A tachy tachycardic rhythm with a heart rate greater than 130 and absent P waves. No, because there's P waves usually. Tachycardic rhythm originating from a pacemaker site above the level of the ventricles. Yes, this is correct. A regular tachycardic rhythm between 150 and 100 beats with P waves buried in the QRS complexes. They won't necessarily be buried. The best answer here is the tachycardic rhythm originating from a pacemaker site above the ventricles. If the patient's EKG rhythm shows artifact, you should. Don't reverse the limb leads. You don't remove the negative lead. You just want to make sure that the electrodes are applied firmly to the skin, right? D. It's the best course of action because sometimes you have electrodes that are dried out or the patient's sweaty or like hairy. Just make sure that they're on appropriately and firmly. Stimulation of the alpha and beta receptors affect what part of the body? Heart and blood vessels, heart only, blood vessels and lungs, or heart, lungs, and blood vessels? Your whole body. Heart, lung, and blood vessels. Atherosclerosis is a process by which plaque infiltrates the arterial wall, decreasing elasticity and narrowing its lumen. Yes, that sounds pretty good so far. Plaque ruptures from a distant location and lodges into one of the coronary arteries. No, traditionally not. That's not the whole idea of atherosclerosis. Calcium precipitates in arterial walls, reducing the elasticity. Now, if you remember, we talked about the difference between atherosclerosis and arteriosclerosis, AT, if you put it in front of it. FAT is fat, which is plaque. Outer wall coronary artery becomes lined with masses of fatty tissue. It's not the outer wall that's the problem, it's the inner wall, where it's infiltrating the arterial wall. Best answer, A. An electrical impulse is slightly delayed at the AV node so that, why? The atria can empty into the ventricles. Yes. Ventricles can contract completely. No, they're being filled at that point. Primary cardiac pacemaker can reset. No, that's already been reset. And the bundle of His can depolarize fully. No, atria can empty into the ventricles. 68-year-old woman presenting with an acute onset of confusion, shortness of breath, and diaphoresis. Pulse is weak, blood pressure 72/50. ECG reveals third-degree heart block. After putting her on high-flow oxygen, you should immediately attempt. Right? This is a medicine or Edison decision, and it's going to be Edison. You need to give her blood pressure is very low, and she's confused and short of breath. This is when you need to pace that lady. Death in the pre-hospital setting following an acute myocardial infarction is most often a result of. We spoke about this. This is one of those knowledge things that you need to have in your head. Ventricular fibrillation is the most deadly, right? Because the heart's going to have electric in it for a little bit. It's going to try to keep going. It's not going to drop straight into asystole. In which of the following situations would you likely not be able to palpate a pulse despite effective chest compressions? Hyperkalemia won't interfere with mechanical, hypoxia or acidosis won't interfere with mechanical chest compressions, tension, pneumo. A middle-aged man is in VFib refractory to defibrillation. You have administered 2 doses of epi and are performing adequate well-coordinated CPR. What do you do next? And we talked about this, right? After epi, after 2 to 3 doses of epi, you're going to give patient amiodarone, right? So you're not going to give vasopressin. You're not going to give lidocaine. You're not going to infuse normal saline. You're going to do 300 milligrams of amiodarone. Again, this is important that you know what your protocols are. You respond to a 48-year-old man complaining of crushing chest pain with radiation down his left arm. Patient administers nitro-SL sublingual while you call medical control, who orders, that you administer nitroglycerin paste. Administering nitroglycerin paste is considered what? Right? You put that on the patient. That's a topical administration. That's a basic pharmacology question. Treatment for a patient with bradycardia and significantly compromised cardiac output includes. So this is also one of those things where you can kind of look at what the doses of the medications are. You don't give 1 milligram of atropine, so that's wrong. We give a 0.5 milligram. Would we give 1 milligram of epi 1 to 10,000? No, not really. That's a little much for a patient who is still alive. Okay. The dosage for epinephrine, push dose epinephrine, is smaller than this. It's 0.1 milligram. Are you going to pace this patient? Most likely, right? This is something that's going to be very useful. We're back to that medicine or Edison. Your medicine option is dopamine. But if this patient is significantly compromised, you're going to go right to that Edison decision. Unlike the parasympathetic nervous system, the sympathetic nervous system is not under the direct control of the autonomic. No, that's not right. Provides a mechanism for the body to adapt to changing demands. Yes, that's usually very good what it does. That's the answer right there. Provides a mechanism for the body to adapt to changing demands. Because it doesn't constrict. This is parasympathetic. Parasympathetic is blocked when atropine is used. So there's your answer. Patients with Wolff-Parkinson-White syndrome experience independent atrial depolarization due to failure of the Bachmann bundle. No, it's not the Bachmann bundle's fault. Don't shift blame where it's unnecessary. Have an accessory pathway that bypasses AV node and causes early ventricular repolarization. Yes, that's the definition of Wolff-Parkinson-White. Are highly susceptible to a variety of bradycardic? No. They're tachycardic. Diseased SA node? No. The SA node's working fine. It just has an extra friend bypassing the AV node. Decreased cardiac output secondary to heart rate greater than 150 beats a minute is caused by what? Increased automaticity of the pacemaker. No, it's not affecting the mechanical side. That's just the electrical side. Ectopic pacemaker sites in the atrial ventricles. Again, nothing to do with mechanical. Decreases in stroke volume and ventricular filling. Yes. Myocardial stretching due to increased preload. No, because if you have increased preload to a certain extent, the output should also increase. The best answer here is C. Decreases in stroke volume. So that's the end of this review, okay? Hopefully this was helpful. Hopefully we've reviewed the items that we may have had difficulty with. If you have any more questions, please let me know. Other than that, good luck in your studying.